All right, so the purpose of this is to discuss the Tracheal weaning protocol and to give a bit of background on the physiology, the rationale for the current protocol, then some operational elements to consider as you're all trainees and fellows that are going to be hopefully shepherding this in and leading the charge. So we wanted to provide a bit of the background and some information and education around weaning in general. An outline for the talk. We'll start off with hopefully the most important, which is who cares? Why are we talking about tracheal trials? Why are we talking about weaning? Some of the benefits of protocolization. We'll go over our protocol and then also how it works and fits into power chart. And then I'll sort of discuss some of the evaluative components and the barriers that we anticipate that have already existed or that might crop up and try and get people's help navigating those. So the first question is the who cares? Why are we, this is a picture of burning ships. Why are we abandoning the old system, which was largely, well, still in existence? And that's an every day, at least once, if not twice or three times per day, RTs, nurses, and physicians talking about how much are we going to trach mask and how are we going to do it? How are we going to wean people with trachs from invasive ventilation? And the rationale is really this, that there are probably a subset of people that were going far too slowly for the tortoises. We trach somebody and then we do 1 hour because we anticipate they're going to be weak. And a lot of these folks could probably go much quicker than that. We could probably expedite the recovery. Whereas other people have the hair complex where they're starting off going very long periods of time or intermittently having longer stretches, and they tire out and then they revert back to failure. So trying to find what is a strategy that works for folks that's not too fast, not too slow. And I think the larger perspective here is this idea that each week and really each day, and maybe each half day, if you're at some of the sites with day and night, we're having a totally new idea around how to trach mask. So 1 week it's CPAP trials, 1 week it's T-piece, 1 week it's off bend completely, 1 week it's weaning pressure support. And it's difficult to do anything well if you do a million different approaches. So with that in mind, what is there? What are the evidence? What are the rationale? What rationales exist for trying to standardize or protocolize this? I think I've talked about this before to the trainees, but Karen Burns and her colleagues, and Karen Burns was at one point in your footsteps here as a Western critical care trainee, looked at protocolized versus non-protocolized weaning for patients with invasive ventilation, and sort of looked at this question, whether or not any protocol is better than ad hoc, expert in the moment decision analysis. And this is the meat of the meta-analysis. This is the forest plot, which shows this is time, total duration of mechanical ventilation by protocol. And you can see at the bottom in the total component here, we have either an SBT protocol or stepwise, but that the net effect favors a protocol and as opposed to usual care. If you look through the actual numbers themselves, they're fairly small. There aren't huge cohorts here. This is a fairly complex, large population to study. But regardless, the treatment effects are almost all universally towards the favor and protocol weaning as opposed to usual care. So if we accept the fact, or if we believe this, we see a reduction in invasive ventilation days by 26%, or time, and then the ICU length of stay decreases with protocolization. That's attractive, that's nice, but what protocol should we take? What should we look at? And Dr. Bosma will go into more depth here, but really one of the foundational support for this current CIRP tracheal trial protocol comes from this paper, which was published in JAMA. The first author is Jubrin, who's a respirology ICU, but Martin Tobin also published this. So for some of the more protocol ventilation weary people, they might remember that Martin Tobin famously said in our critical conversations that protocols help the worst doctors cause the least harm. And yet he was an author on this publication. So just a bit of food for thought. The background here is they looked at all patients who were going to long-term acute care hospitals in the United States. Once you reach 21 days in the US, your insurance changes over, so they transfer people to less acute areas, which are called LTACs. And many of these folks in LTACs are invasively ventilated. So they looked at that population of people. They did a screening period where they just did 5 days of go as long as you can, on trach mask with no support and only intervene in the times of failure. And then if folks were still ventilator dependent, then they went through a different process. So the screening here, I mentioned 5 days of unassisted breathing with just rests as needed. And then if they were remaining on ventilation at that point, they would do either trach collar, which was as long as they could for 12 hours, and then back on the ventilator for pressure control overnight, or a down titration of pressure support. So assessing them 3 times daily, decreasing the pressure support as long as the respiratory rate was under 30. And then once they got to pressure support of less than 6, then they switched over to 5 days unassisted. What did they find? One of the interesting things here, which I think speaks to, are we going too slowly with folks, is that of the 500 patients they enrolled, 184 or 32% did not require the ventilator after the screening period. So if they put folks on 5 days of just take them off the ventilator completely, and these are people that were ventilator dependent, leaving ICUs, 32% were liberated immediately and never even got into the true trial. And then they found that if you look at the trach collar, trach mask group that was just 12 hours on, 12 hours rest, the median duration of ventilation was 15 versus 19 days. 53% were weaned with 10% death, as opposed to the pressure support group, which was lower probability of weaning and higher probability of death. The one caveat I'll put here for, and again, Dr. Bosma will explain why we adopted some parts of this for ours, but not others, is LTAC patients are largely, once they get to 2 weeks or they think they're going there, the ICUs, the acute ICUs often stop trying to wean people. So it's not surprising that 32% were immediately weaned, or that is surprising, it's a higher number, but it might not be directly applicable to our setting. And with that, I'll pass it off to Dr. Bosma.
So as Dr. Cameron said, that study by Martin Tobin and Amal Joubran was really a landmark study that changed the way we think about both pressure support versus assist control, because those patients were rested on assist control, and trach mask trials. We used to follow something very similar to the CCSO protocol. So our standard of weaning was formerly, Paul, if you can just go back one slide, was formerly this idea of get them on pressure support, get them tolerating pressure support around the clock, and gradually wean the pressure support. And once they can do pressure support of 5, then they can start trach mask trials. And this study also showed us that maybe that approach is not necessary. And so we like the CCSO protocol in that it was a protocol. So protocol is better than no protocol, but we thought we could do better. Next slide, please. So I think as residents, as senior residents, you guys all know that to get somebody off a ventilator, we need to look at both the load on the respiratory system as well as the respiratory system capacity. And I think you guys are all really good at looking at the load. So that side is taken care of. You know that we need to decrease CO2 productions. We need to treat their sepsis. We need to decrease their dead space. So we need to treat their pulmonary embolism and rule that out. We need to decrease their PEEP if we're causing increased dead space. We need to decrease their drive. So we need to treat their metabolic acidosis. We need to improve their compliance. So we need to diurese them. We need to decrease their resistance. They need bronchodilators and prednisone if they're asthmatic or COPD. So I think you guys have that part under control. What this CIRP weaning protocol focuses is the other side of the equation. How do we increase their capacity? So assuming that they have a central drive intact, they're not brain dead, their brainstem's working, that they have an intact phrenic nerve, they don't have an axonal GBS. Then how do we help the respiratory muscles improve? And our respiratory muscles need to generate normal muscle force and effective pressure gradients and have the endurance to sustain that. Next slide. So to get them off the ventilator when the load is higher than the capacity, we add the ventilator, and we need to be able to get it so that the muscular load of the patient, the muscular capacity, is higher than the load. Next slide. So why does muscular capacity decrease when we're on a ventilator. And I think most people are familiar with this work that came out in the New England Journal of Medicine back in 2008. So this was a study where they looked at taking diaphragm biopsy specimens from adult brain dead organ donors at the time they went to the OR. And these brain dead organ donors had been ventilated for 18 to 69 hours. And they then had a control group of patients who were undergoing thoracic surgery who were not brain dead, living patients, and they did biopsies on them. And those thoracic surgery patients had only been ventilated for 2 to 3 hours at the time of the OR. And they found that after brain death, within hours, you already had diaphragm muscle atrophy. The diaphragm was meant to contract every breath of our entire lives. And if it stops contracting, those fibers very, very quickly, within 18 hours, are showing atrophy. Next slide. So complete diaphragm inactivity during controlled mechanical ventilation can result in diaphragm muscle fiber atrophy and contractile dysfunction with reduced force generating capacity. And so we try to avoid having people completely paralyzed in the ICU and not using their diaphragm at all, because we know that they will have a weaker diaphragm after that. And so we try to have patients on partial modes of support and triggering as much as possible. Pressure support is the most commonly used mode worldwide in observational studies for patient-triggered spontaneous breath delivery. But very interestingly, even on pressure support, you can have diaphragm atrophy occurring. So a study done by Hudson and colleagues published in 2012 in Critical Care Medicine looked at rats who were randomized to 12 and 18 hours of pressure support or controlled mechanical ventilation and compared to rats with no mechanical ventilation. And looking at, again, biopsy specimens of the diaphragm showed that even on high pressure support, so those rats, were triggering every breath. And yet, because that diaphragm didn't have to do a lot of work, it was also atrophy. So atrophy can occur with high levels of support. So then if we have this patient who's been in our ICU and they've been paralyzed and they've been sedated and they've been on controlled mechanical ventilation or even high pressure support mechanical ventilation, we know that their muscle capacity of their diaphragm is poor. And now we need to look at how are we going to get them to be able to be liberated from the ventilator. So a good analogy I use is like couch potato who decides he or she wants to run a marathon. So that's really an important analogy, because for these patients with a weak diaphragm who've been in bed, resting their diaphragm for so long, that's really a good analogy. So the first key thing is it safe to exercise? So for this couch potato, you want to know, if you are a couch potato, am I going to get angina? Am I going to have an MI the first time I get up? And am I going to have an asthma attack? So before we just put people on the road to exercising, we need to do some screening tests to make sure physiologically it's not going to be dangerous to get up and exercise. Next slide. So the next part of it is if it's safe to exercise, then how am I going to get from 0 kilometers to 42 kilometers to this marathon? And for people who are planning to run a marathon, they often have a daily schedule and a weekly plan and an overall goal of how they're going to get there. And so that's kind of the basis for our CIRP weaning protocol. So we have workouts, just like someone training for a marathon. They might get up and they walk, and then they might start having short runs and walk in between. So they might run for 5 minutes, walk for 2 minutes, run for 5 minutes, and build up that way. And then they rest at night. Sleep and nutrition, we know, is extremely important for athletes. So it's not just about getting out and running every day and increasing your endurance and your distance. It's also what you do when you're not running. And so don't think that you can just run and then get back on the couch and eat potato chips. You also have to think about how well you're sleeping and your nutrition. So in our weaning protocol, we have first establishing clinical stability for weaning, and then we have the initiation of trach mass trials. That's like getting out and running. And then at the end, we talk about actually liberating from overnight and taking that last step. So in terms of that first safety assessment, is it safe to exercise this patient? So we are suggesting that anybody who's trached you can order the CIRP trach weaning protocol on, and the RTs will just initiate that, but first they have to make sure the patient's safe. So do not proceed with trach mask trials if any of the following are present. If the respiratory rate's already high, the SATs are low, there's uncompensated acidosis, or of course if neuromuscular blockers are in use, and or if there's unstable hemodynamics. So if the patient's on greater than 0.5 mics per kilo per minute, so 70 kilo person, that's 35 mics per minute, talking in our language. So the patient's on fairly high dose vasopressors, or the vasopressors are rapidly escalating, not a good time to start weaning as the levofed and epinephrine are rising. If they're already hypotensive or in unstable arrhythmia or uncontrolled hypertension, if they're having active cardiac ischemia, if they're dangerously agitated, or any other emergency situation, it's not the right time. Next slide. And then stop if they pass that screen and start on their trach mask trial. We're also going to stop if they develop tolerance, evidence of intolerance or failure. So they're dropping their SAT, their rest rate stays high, they become tachycardic or hyper or hypotensive, they have significant anxiety or dyspnea. I always tell residents, people don't just develop panic attacks all of a sudden when they come to the ICU. They don't suddenly develop an anxiety disorder. If they're anxious, it's because they can't breathe and they have that sense of impending doom. You need to listen to that. That's because they can't breathe, and you need to fix that with the ventilator. If they have worsening accessory muscle use or is suddenly become unconscious, obviously their CO2 is rising. Okay, so what is the plan? So again, similar to a 6-month couch to marathon training plan, we have a baseline assessment. We establish a daily workout schedule, and by workout, I mean trach mask schedule, and then overnight assessment and transition. So the baseline assessment is, can they try their first trach mask trial? So our screening assessment is a rapid shallow breathing index. So just like we do for spontaneous breathing trials for endotracheally intubated patients, we just look at them off support, take away positive support and whatever PEEP they're on, and let them go for 2 minutes and see what they do. 2 minutes is probably safe for most people. And so you're going to be looking at the patient closely. They're not going to get into too much trouble within 2 minutes. So if their RSBI is less than 105, and their PEEP is less than or equal to 8, regardless of what support they were on before, after 2 minutes of no support, if they can do that, they're good to completely come off the vent and have a trach mask trial. If they fail that, so can they at least have a CPAP trial? So their frequency tidal volume ratio was less than 105, but they were on a PEEP of 15 when you did it. That might be kind of a big drop to go from 15 to 0. So then do a CPAP trial. And if not, if their RSBI was greater than 105, maybe they're not ready to go directly to trach mask, but could they have a pressure support or PAV trial? And then step 2 is, once you put them on trach mask, how long can they go? So this is our first screening readiness page. So they meet trach mask trial criteria. They passed all the table 1 criteria. Then you're going to do the daily trach mask trial screen using your RSBI. So take away any positive pressure support or any pressure control or volume control, and you assess them after 2 minutes. If they, again, pass their screening test of 2 minutes and their CPAP was less than or equal to 8, you're going to start with your first trach mask trial. If not, you're going to keep them on CPAP. And if they failed with their FOVT greater than 105, then you're going to perform a pressure support trial, seeing if you can maintain them on pressure support and maintain their P0.1 between 1 and 3.5. And I'm going to talk about the rationale for that shortly. And then when they tire out on pressure support, you're going to rest them when needed. So if they develop intolerance to either their trach mask or their pressure support trial, they go back on the vent on a assist control mode. And then always at night, we want to rest these patients and using either controlled pressure control or adaptive support ventilation, ASV. So once we get past that initial tracheostomy attempt, that initial tracheostomy screen, so they're ready to do their first trach mask trial. So we want to make sure the patient's in the best position and optimized, so hopefully upright in bed unless contraindicated. And you let them go on their first trach mask, and you're going to let them go. If they tolerate that first 15 minutes, you're watching closely, then the RTs can walk away and the patient's on monitor, and we're just going to let them go until they develop signs of early failure. So on their first trach mask trial, it's really to see, this is your baseline assessment, how far can you go? And some patients, if they were really only trached for airway protection, might not need the ventilator and might look perfectly fine going all day and all night, and that's okay. If they weren't able to go more than 6 hours in that first stint, then we have our baseline assessment for how far they could run, and we're going to build on that by increasing the duration in increments. So if they on the first day went greater than 6 hours, if they went less than 6 hours, it brings us to this box in the middle. So if they went less than an hour, then you're going to try to increase your trach mask trials by 15 minutes. So say they went half an hour on their first day, their next trach mask trial, you're going to try to go 45 minutes, and you're going to try to do that twice a day, 45 minutes twice a day. That's your aim for the next day. If they went greater than an hour, but less than 6 hours, you're going to try to increase both trach mask trials by 30 minutes per day. And if they went 3 to 6 hours, you're going to try to increase by 60 minutes each trach mask trial. So every day is a marker of how much you're going to try to exercise that patient the next day. If they're not able to get their goal, so if day one they did 30 minutes, day two the goal was 45 minutes twice during the day. If they couldn't do 45 minutes, then you're just going to aim for that the next day. We say aim to do the trach mask trials at around 10 a.m. and again at 4 p.m. But really that's up to the physiotherapist and the nurse at the bedside and the RT to come up with a plan, because we want to make sure again that the patient's optimized. So probably they do their trach mask trial and then do their physio, for example, or just so that they don't compete. We're not trying to do everything all at once. And then when in between trach mask trials, we're recommending at least 2 hours of rest between trach mask trials. And again, rest is on pressure control or ASV. If on the first day, they tolerated more than 6 hours of trach mask trials, then the next day you're going to try to increase that by 2 hours from the previous day. And there's an optional short trach mask trial in the evening as well, but rest at night. And you're going to continue building with these increments until they can get to 16 hours of trach mask. If in the initial day, they didn't even tolerate 15 minutes, they could only go 10 minutes, they looked horrible, they had to go back. Then what we're going to do instead is try pressure support trials, maintaining that work of breathing, that P01 between 1 and 3.5, and resting at night, trying to address any other factors that are increasing the load on the respiratory system, and then daily screening to see when that patient can try trach mask trials. Sometimes patients will day after day not tolerate trach mask trial increments, and then at the top of the screen, that's where again, sometimes we have to just put a hold on further trach mask trials because they're not making progress and address other factors. So for example, we might have a patient that's nutritionally deplete. Maybe they're in a negative nitrogen balance. They're catabolizing more protein than they're creating. Those are patients where if they're repeatedly failing, there's no point in just continuing to do what we've been doing without success. We need to sometimes take a break and say, halt further weaning attempts until we get their nutrition sorted out, or halt further weaning attempts until we get this VAP treated. So those are the kind of things where we might hold and not continue to flog the patient that just can't exercise, and resume when the team determines appropriate. So that's an overview of the trach mask trials. And next, I'm just going to go into some of the evidence for this. So as I mentioned, there's sort of 3 levels of exercise: run, walk, and rest. So by run, we mean trach mask trial or CPAP trial, where there's no inspiratory support and all the work of breathing is done by the patient. By walk, I mean there is some support for this exercise. So either pressure support or PAV, and the work of breathing is shared by the patient and ventilator. And it's important that their work of breathing when on the ventilator is not excessive and not negligible. So the question is, how do we determine what is acceptable workload of breathing for the patient, and why do we care? By rest, we mean the majority, if not all, the work of breathing is done by the ventilator. And that might seem counterintuitive, because I just told you that we don't want patients on controlled modes of ventilation because they're going to get weaker diaphragms. This is a little bit different in that we've been exercising them during the day, and now we want them to completely rest. And by rest, I mean rest the respiratory muscles and also promote sleep. So we know that restful ventilation is really important to enable that recovery of the diaphragm that you've been working out so that they can exercise again the next day. Next slide. So why is work of breathing important? So I told you about ventilator-induced diaphragm dysfunction for atrophy, but there's also overuse injury and fatigue. So excessive workload on the diaphragm for a patient in respiratory failure may induce injury due to fatiguing that muscle. It can also lead to clinical distress, myocardial ischemia, lactic acidosis. It can also further perpetuate lung injury. So if you have a patient, for example, who's recovering from ARDS and that lung is still inflamed, and now you're trying to wean them, but they have excessively high transpulmonary pressures because their efforts are so big, you could actually exacerbate and worsen their lung injury. And then if, last but not least, there's significant effects on cardiac function when you have a patient that's having huge transpulmonary pressures. And so it's not uncommon for our patients who we try to put on trach mask trials, they can go into flash pulmonary edema. So all of those are important, and that's why we don't want to have overuse injury by making the patient work too hard. So this is a really interesting study by Ewan Gallagher and colleagues in Toronto. And Ewan Gallagher uses ultrasound to look at diaphragm thickness during mechanical ventilation, and has identified sort of 3 groups of patients. So the graph shows in the red patients for whom diaphragm thickness decreases dramatically over the course of their mechanical ventilation. The group in green are those that stay relatively the same. And then interestingly, there's a group of patients, the blue, for whom the diaphragm actually becomes thicker during mechanical ventilation. And you might think that's good, like you're building muscle that's thicker, it's good. But in fact, when they looked at those group of patients, it was 13 patients, so small numbers, but physiologically enough to get a signal. 13 patients exhibited an increase in diaphragm thickness over time. And although increased diaphragm thickness following exercise training has been associated with increased strength, functional measurements obtained in 3 of these patients revealed marked weakness, suggesting that this increase in thickness may be related to structural injury rather than a lack of atrophy. And so there's further data that I haven't shown from Ewan Gallagher's group that shows that this thickening of the diaphragm, when it's not associated with improved contractile function, likely relates to inflammation and swelling rather than truly improved diaphragm fiber thickening and improved contractility. So we have to be really careful that we don't overuse the diaphragm and have the patient under too much workload, because physiologically that can be bad for the diaphragm. It could actually be injury and not recovery. And the graph at the bottom shows that the patients that had increased thickness over time were the ones that had a lower driving pressure on the ventilator, so they weren't as supported. Okay, next slide. So because we want to make sure that we're not having these patients further atrophy their diaphragm, and because we want to make sure that we're not being prone to excess work and overuse injury, it's really important to have some quantifiable measure of the patient's workup breathing. So one way to do that, to actually know how much pressure the patient's generating with the respiratory muscles, is to put in an esophageal balloon. Now, when we put in our esophageal balloons and hook patients up to the ventilator, we can measure the delta P-ESO, so the change in pressure from baseline to the lowest point. But we can also measure the area under the curve. So that area in green between the line indicating chest wall elastance and the line indicating the esophageal pressure, that area under the curve is called the pressure time product. And a normal pressure time product is between 60 to 150 centimeters of water per second for breath, and then we multiply that by the respiratory rate to get a minute value. So we can actually measure if the workup breathing is being maintained in normal range. And when that's estimated, that a normal delta P-ESO for patients that is comfortable breathing is 5 to 10 centimeters of water. Now, we don't have esophageal balloons in all of our patients, and certainly not when they're kind of awake and weaning, although we could. So there are other ways of knowing how much patients are doing in terms of their workup breathing. If we have them on proportional assist ventilation, we can actually know their PMUS and calculate it and aim for 5 to 10 centimeters of water. So if you have any patients in the promising study, you'll see us calculating their PMUS and adjusting PAV to keep it in that normal range. But if they're on pressure support, then there's no direct knowledge of the workup breathing and we need a surrogate. Next slide. So that's where the P01 comes in. Now, I will note that P01 is not an indication of patient effort, okay? Because you're not measuring the nadir of that airway pressure curve. It is a measure of drive, but it's a surrogate measure of effort, as shown by a really great study by Irene Telius and colleagues. So what P01 is we're not looking at esophageal pressure, we're looking at the airway pressure. And when the patient triggers the ventilator, how much that airway pressure drops in the first 100 milliseconds or 0.1 seconds is the measurement of the P01. If the brainstem is yelling at the diaphragm, like take a big breath, that drop will be very significant. And likely will reflect a big complete nadir in that curve. And if the patient is very relaxed and passive, that drop will be very small. So in healthy subjects, the P01 will range between 0.5 and 1.5 centimeters of water. A P01 greater than 3.5 may indicate excessive inspiratory effort because if they start off that fast, they're probably ending with a big bang. And then P01 less than 1.6 probably denotes that the patient is too passive and over-assisted. Next slide. So this is the paper I was discussing about done by Irene Telius and Laurent Bouchard. And they hypothesized that monitoring and controlling respiratory drive and effort may help to minimize lung and diaphragm injury. And said the airway occlusion pressure might be a good way to do this. Next slide. And so what they did is they put in esophageal balloons with patients and looked at the P01 measured by the ventilator. And they found that P01 by the vent correlated well with measures of drive and with the esophageal pressure time product that I talked about. That had good correlation. And the P0.1 reference value greater than 3.5 had an 80% sensitive and 77% specific for detecting high effort, and P01 less than 1 was 100% sensitive and 92% specific for detecting low effort. So outside of that normal range, at which time the patient's at risk for atrophy or at risk for overuse injury. And so they concluded that P01 was a reliable bedside tool to assess respiratory drive and to detect potentially injurious inspiratory effort. We don't know if keeping the P01 between those normal values improves patient outcome, but because there's evidence and what we're trying to achieve is reduced atrophy and reduced injury, we thought we would include it in our protocol, even though it's hypothetical that this will be helpful, but at least at some measure, I think it's better than having no measure of what the patient's doing. Next slide. Okay, so that's the rationale for when we have a patient on pressure support to maintain their P01 between 1 and 3.5, or if you have your patient on PAV to keep their PMUS that we can calculate between 5 and 10. Next slide. Okay, and so again, if they're not tolerating trach mask trials, we have them on pressure support, maintain that normal workup breathing, and I think the rest of the slide I've already spoken to. Okay, so why do we rest in between, and why do we rest on assist control at night? So I'm going to talk a bit more about that. Dr. Cameron went through this study already, but I just wanted to point out that sometimes people have the impression that if a patient is not on pressure support, then they're not making progress. And I think that that's a false assumption based on this study, because Martin Tobin showed that patients who were in the tracheostomy collar group were rested not on pressure support, but on assist control. So resting on pressure control and then doing your trach mask trials was superior to being on pressure support continuously and decreasing your pressure support levels. So this idea that we're not making headway if the patient's on pressure control is a false one that I want to challenge. Next slide. Okay. What about when we put patients on the trach mask trial? So in our protocol, as you saw, we allow for daily increments that are based on that baseline assessment. So if the patient did less than an hour their first day, we're only increasing them by 15 minutes every day. These are slow increments like the hair. And people might get impatient and say, can you just carry on already? Like, I think this patient can do more. So we see that all the time. Patients, the plan for today is 45 minutes. And the next thing I know, I come back and the patient's on their 3rd hour and they look great. And people think that's a big success. But I'm worried that the next day they're going to pay for it. And that's what people don't see. The RT goes home, the resident goes home. And the next day we see that the patient has not tolerated a trach mask trial at all and looks horrible. And that's because we've harmed them. Is there potential, do I have any evidence for that statement? Is there potential clinical harm from pushing them too hard in their exercise? And similar to the marathon runner, is it bad to go run 1 kilometer on day 1 and then go 10 kilometers on day 2 and think that that's okay? So this is a study by Dr. Esteban and colleagues published in New England Journal of Medicine in 2004. And this study, it was not about trach mask trials. This was about letting patients go too long in respiratory failure. So this was a multi-center RCT, and they looked at patients who were intubated for more than 48 hours. And then when they were electively extubated, within 48 hours, they developed respiratory failure. So these are failed extubations. And they randomized these patients to non-invasive ventilation or to standard therapy, but they couldn't have NIV. They could have physio, they could have antibiotics, diuresis, whatever. So in the standard therapy group, some patients crossed over to non-invasive ventilation. And out of the 107 patients in the standard medical therapy group, 51 required reintubation, so about half. In the non-invasive ventilation group, 55 needed reintubation. So again, about half. So whether they got NIV or standard medical therapy, no NIV, half needed reintubation. But what's interesting here is that in the group that required reintubation in the NIV arm, 21 out of 55, or 2/5, died, and only 1/5 died in the reintubation group in the standard medical therapy. So why is that? Well, the only difference between these two groups that got reintubated was that the median time to reintubation in the NIV group was 12 hours, and the median time to reintubation in the standard medical therapy group was 2 hours. So the patients that failed their extubation, where within 2 hours we said, okay, things aren't going well, they need to be reintubated, had a better chance of surviving than the patients that we left in respiratory failure on NIV, and they eventually needed intubation, but we waited a long time. So that tells us that leaving patients in respiratory failure, if they're ultimately needing to go back on the vent for too long, is harmful. And given the evidence that I showed about increasing diaphragm thickness and cardiac instability and the lung-heart interactions and potential lung and diaphragm damage that can happen if we leave our patients in respiratory failure too long, that's why we're very cautious in this weaning protocol to say we need to build up gradually. They're not going to increase their endurance from 1 hour to 24 hours in a day if they couldn't do it on day one. If they failed on day one, they need to increase gradually. Okay, so we don't try to run that marathon in 1 week. This is a gradual process. Next slide. Okay, so last thing that I want to talk about is resting at night. So what do we know about the relationship between sleep and respiratory muscle performance? So we know that in healthy subjects, if you have a sleepless night, there's a small but statistically significant decrease in your ability to sustain a maximum voluntary ventilation, decreased hypercapnic ventilatory response slope, and decreased forced vital capacity. And that's just in healthy patients after a night of sleep deprivation. Next slide. We also know that after sleep deprivation, you have decreased respiratory muscle endurance and decreased 12-second, again, maximum voluntary ventilation. Next slide. So what about sick patients with respiratory failure? So this was a study, an observational cohort study of 27 patients who had hypercapnic respiratory failure and were on NIV. And they measured polysomnography to look at their sleep. And they found that abnormal sleep patterns after initiation of NIV was associated with late NIV failure, meaning those patients ended up dying or being intubated or couldn't come off NIV by day 6. So patients that had poor sleep had ongoing respiratory failure compared to patients that had good sleep. They got off NIV, they recovered. Next slide. Also, this is another study looking at mechanically invasively ventilated patients where polysomnography was performed after the first SVT failure in ICU patients, and 44% had atypical sleep, and the weaning duration was longer in patients with atypical sleep versus those without. And atypical sleep remained independently associated with prolonged weaning. Even when correcting for other factors. So does poor sleep cause weaning failure? We don't know. It's an association, both in non-invasive and invasive mechanical ventilation. There's an association. Does improving sleep improve weaning outcome? We don't know. But given, again, that there's these associations and we're trying to do everything we can to help these patients, we felt there was enough evidence to promote good sleep. Next slide. So how does respiratory failure, mechanical ventilation, and patient ventilator interaction impact sleep in ICU? So looking at polysomnography and patient ventilator interaction and asynchrony, we have found that, next slide, in patients with acute hypercapnic respiratory failure, I talked about that sleep quality is better on NIV than off. Respiratory muscle rest, if we put patients on pressure control ventilation and we completely rest the muscles to achieve passive ventilation, those patients have improved sleep quantity, efficiency, and REM sleep compared to whether you let them go on low pressure support all night. And then overventilation can induce central apneas and sleep fragmentation compared to pressure control. So 3 studies showing that if you support the respiratory muscles, you improve sleep. Next slide. If you have excess asynchrony, you will have more sleep fragmentation than if you have improved synchrony. Next slide. So what we know then about improving sleep, we know that the work of breathing is important. If patients are working too hard or not enough, they're excessively ventilated, they will have poor sleep. If there's asynchrony, they will have poor sleep. If there's over assistance, they will have poor sleep. NAVA and PAV have been shown to improve patient sleep. PAV, there's less evidence for because there's conflicting evidence, but NAVA has consistently been shown to improve sleep. So again, getting that synchronization and work of breathing correct is important. Next slide. So several studies have suggested that if you have the patient correctly supported on assist control ventilation or pressure support ventilation, but with the right level of support to ensure normal work of breathing, or synchronous on PAV, you will improve sleep fragmentation. Next slide. So that's why we say at night, don't try weaning. Make sure that they are well supported so that they are rested, they have good sleep, their diaphragm and respiratory muscles can have a recovery period and they'll be ready to go the next day. So in our protocol, we have said, put them on pressure control or adaptive support ventilation, which will ensure they're either getting pressure control or pressure support, but keeping them within a good range of tidal volume and respiratory rate overnight. So ASV or CMV is what we propose. Okay, so the ventilator settings at night, we want to avoid hyperventilation. So if you see central apneas developing, you're overventilating your patient. We want to alleviate the work of breathing. We want to sort of target 6 to 8 mils per kilo tidal volumes and respiratory rate, even up to 30, 35, but closer to 20 to 35. And we want to avoid asynchrony. Next slide. So finally, you will get your patient by resting them and doing daily increments in your trach mask trials. You'll get to them to the point that they are tolerating 16 hours of trach mask per day. And at that time, it's time to see if they can go overnight. When you go overnight, keep in mind that we're looking to see how they slept and whether they're getting more delirium, but also whether they're maintaining their CO2 overnight. So we ask that we do blood gases in the evening and the morning to compare after their trach mask trial overnight, or blood gas plus TCO2 monitoring, transcutaneous CO2 monitoring. If we see that CO2 climbing overnight or in the morning, then we assess whether or not they might be a nocturnal NIV candidate, and we might try to transition from invasive to non-invasive ventilation overnight. This is one box that just says nocturnal NIV, but obviously there's a lot more to it. You need to make sure that they can tolerate downsizing of their trach, cuff down overnight, have a good fit, and can tolerate NIV. So there's much more to it than just a simple box. If they're not a good nocturnal NIV candidate, then we might need to just be more gradual in our stepwise approach to lengthening the duration off ventilation overnight. But keeping in mind that we need to keep a close eye on their CO2 and gases. It's not uncommon for patients to pass the first or second night and fail about day 4 or 5. And we don't call it success until the patient's off vent for 7 days in these difficult to wean patients. So that's all that I wanted to say. I'll hand it back over to Dr. Cameron to just walk through how you order this on PowerChart and a few last thoughts. And to Gabrielle, yes, we have transcutaneous CO2 monitoring available in MSICU. There's just a couple of machines, so as long as they're not in use, you can order it.
Yeah, so I'll just finish off with some logistics. The CIRP, you can see here, that's just how you run your power chart. It's live. There are 3 phases, which just systematize those flow charts we've been talking about. This has certainly been, there are efforts to adopt this at all of the university hospital sites, so MSICU, CIRP, and CSRU. There's been interest expressed in the RTs at Vic, but it hasn't certainly been rolled out in a dramatic fashion there yet. So if you order it at UH, people should be familiar with this protocol as we get more buy-in. This is just, I guess, showing you that the evidence base and the tables we talked about are available as drop downs. When you order this, we have this, the first step was there, the second step is here, and again, this just translates that chart into power chart format, and then the third step as well. You can sort of dynamically go back and forth between steps if you need to, and then you can see here, Gabriel, that the transcutaneous TCO2 monitoring is here, and this is certainly available at UH. This is showing that it's sort of a cascade here where you can initiate and then discontinue. You can go back and replicate if you want to go to a different step. So you can adjust this as you move through the protocol, going backwards and forwards if things don't progress. I'll briefly wrap up 2 minutes with the goals and the outcomes. One of the main goals is to reduce the inter-individual variability. As I mentioned, every week or every day, changing the plan is probably less successful. You could probably do anything, but you have to do the same thing in order to achieve consistency. We want to achieve faster weaning, and I personally want to have less "what are we doing today" conversations, because paradoxically, if you answer that question, you're not doing the best thing for the patient, which is to have some sort of systematized protocol to decide this. So I try to avoid answering that question, and it is part of one of our goals. In terms of the evaluation of this, it's an evolution. This is a marker of the patients that we track in CIRP. Some of the data we're starting to look at when they were admitted, the date of the first trach mask, the duration, the initiation of speaking valve, when they were off ventilator, and then notes as we try and gather more information. And your frontline experience with the logistics of implementing this would be helpful to inform us about further modifications that we need to adjust. The culture I'll skip through, but we're trying to, everybody is aware that the person in charge or the people in charge can just deviate. Dr. Butler, who's made efforts to sort of get all of the consultants on the same team so that we're promoting this within our group. The barriers, and I think the major barriers that we're going to address, sort of the loss of creativity and autonomy. People think I would say every RT, every physician thinks that they can devise that perfect plan to wean the patient, and that may actually be true, but 50 plans doesn't work, and it's better to have one that's close enough in evidence base. Fixing what ain't broke. I think that this is an area that's been consistently identified by RTs and physicians as being a stumbling block and something that impedes our progress. And then the others, I think I've sort of addressed. So in conclusion, I think something's better than nothing. I think we've identified that there's benefits to having standardization here, and we've adapted some of the newest evidence that can come into this. The idea of consistency and defaults. Our goal is for the RTs to internalize this, and that's a work in progress, but also you as frontline providers to sort of make this the default so that you can deviate when things need to be done differently, when there's something that's not fitting with this pattern. This is not that prescriptive or hand slapping, but it's meant to sort of drive the default behavior, and it's fairly quick compared to our normal process of weaning. And I think we do know how to wean at this institution, and you as seniors, some of the unique features that are I think valuable that Dr. Bosma was touched on is resting people overnight. No one's getting weaned off the ventilator when they're trigged for 3 weeks overnight. So rest them overnight, promote rapid weans with exercise during the day. And then we talked about targeting pressure support to P0.1. So with that, I will stop sharing. And see if anybody has questions.
This is Ray Kao here. Great job, Karen and Paul. I think this is very, very important. I know John Landau already asked this message. I think this can be also applied to CCTC. Is a way of using the same sort of plan that you guys have developed that we can use the CTTC for our weaning patients here instead of transfer to EICU every time?
Yeah, so there is. I think that it's a bit of knowledge translation. I'm happy to, and Dr. Bosma, I'd be happy to speak to the RTs. Michelle Stevens was on some of the planning for this. I've reached out to the folks at CCTC to see if they want either consultant and or RT education. I think we're still that's still in progress, but absolutely. I just think if you order it this afternoon, the RTs haven't been formally sort of taught on this, or that this is a culture change. So I think that piece needs to be adjusted, but functionally, Michelle Stevens is interested. I think that there's a space for that, Dr. Kao.
Yeah, thank you so much. But I think Dr. Landau, myself, online, other consultants are pretty busy. I think all of us within, if I can speak for John also, that we are very much interested in this. I think weaning, we need to have a collective agreement how to deal with these patients, because every time we go, each week, every consultant have a different idea, although the aim is the same, but the problem is that we'll have a different approach. I think your approach is excellent with Karen, and I think we'll be definitely can use this.
That's really exciting to hear, Ray. And so just some of the barriers you might encounter, and Michelle Stevens will be a real champion for sure. We had, when we wrote this, we sort of had it in language that was universal. So we said like leave a fed greater than 0.5 mics per kilo per minute, but we talk in mics per minute. So Michelle was working just to say, like, if they're on, greater than 10 mics per minute, then they're good for a trach mask trial. If they're greater on 35 mics per minute, they're probably not. So just translating those things. And then the other caveat is just the P01, but that's so easy to do. Just in order for it to show up on the vent, you just need to make sure you're on pressure triggering and not flow triggering. So that's just a simple fix, because otherwise it'll be blank. So you just have to have the patient on pressure triggering, and then you'll see that P01. Even that's an easy step to get the RTs documenting that in PowerChart and adjusting support to ensure that that's in that range. That's just like an easy thing. And the last thing, if someone said, what's your evidence that this protocol works? We don't have evidence yet that this protocol is better than other protocols. It's not been tested against other protocols, but as Paul pointed out, there's good evidence that a protocol is better than no protocol. And it's not, at least it's based on some physiologic principles that make sense about what we know about diaphragm function and weaning. So I don't have hard evidence that this will improve outcomes compared to, for example, the CCSO protocol. But it's something that I think is worth trying and helping us to collect evidence. And the last thing I'll say is that we are very much open to feedback on this. So if you have specific things that really aren't driving for your group, let us know, because we can, make tweaks or make suggestions for that. So we chose ASV as a resting mode because that seems to be a very popular mode across all the sites. But you might have patients, for example, that are better on pressure control or whatever. But it's meant to be a framework for you to work within, not, as Paul said, something that's so stringent. But these guidelines are meant to detect those patients that have, for example, a brain injury and a trauma, but their lungs and muscles are good and they're an early trach, they might fly off the vent, which is great. And pick out those patients where their first and second and third trach mask trials don't go so well. So we need a long-term game plan in mind of how we're going to increment them.
Absolutely. I mean, when I was working at CIRP with Brittany, we went through this process and find out these patients probably were able to go ahead of the protocol, and they were able to be off the vent quite quickly. So I'm glad there's that flexibility within the protocol that you can change, adapt to the patient's needs. Thank you.
Any comments from any of the fellows? Mike, you're unmuted.
Yeah, I just had a question. Really, really cool. I like this. It's a lot. I'm curious to see how it goes. But just wanted to clarify a few things in between. So for the patients that are getting rested overnight, if you pick ASV, do we have any restrictions in terms of the support with ASV, in terms of, like, should they be 100% predicted, or is it as per usual in terms of meeting the usual requirements? And the same question, I guess, in terms of if they've rested their minimum 2 hours, if they're on the BID trach mask trial kind of arm of things, outside of those 2 hours, should they be continuing on ASV for the most part, or is that still debatable?
So for overnight, when they're on ASV, look at the patient really is more important than how much support they're getting. So 100% is a good starting point on ASV, but if you find that they are asynchronous on that, you might have to go down, or if they look like they're working too hard or not sleeping, you might have to go up. So it's really based on those guidelines of, does the patient look comfortable? Is their rest rate okay? Is their tidal volumes okay? Are they having synchrony or asynchrony? And then in terms of the resting for at least 2 hours between on ASV or CMV, so it's the at least 2 hours in between. And the amount of time they're rested is going to vary depending on how long the trach mask trials are on either side. On ASV, if they're active, they're going to be on pressure support anyway. So it's sort of a judgment call. I think your question is, can you be on pressure support after your 2 hours of rest? Yes. And on ASV, they might end up being all 100% spontaneously triggered, in which case they are on pressure support.
Perfect. That's great. Thank you so much.
All right, it's 1 o'clock. I will probably stop the recording and excuse anybody who wants to go. If anybody wants to hang around and ask questions, we'd be happy to. But thanks everyone for showing up. For the seniors, appreciate your time, and we will see you again tomorrow at half day. Thanks everybody.